Hello, ViaQuest family. My name is Kim Weitzman. I'm a QA and training manager from the North region. Welcome to the training titled Understanding VPBS. The purpose of today's training is to give you a basic understanding of VPBS and to hopefully help you understand when you may be able to refer a client to VPBS. So let's go ahead and just get right into the training. So first of all, VPBS stands for ViaQuest Psychiatric and Behavioral Solutions. The clients that we serve are clients who are struggling with mental health issues, substance abuse, challenging behaviors, clients who are within long-term care facilities, and clients with intellectual and developmental disabilities who have co-occurring mental health issues who are located throughout Ohio. So who else are we serving? We are offering unique and person-centered care to children, adolescents, and adults who have psychiatric and behavioral needs. We also offer specialized treatment for clients who have intellectual and developmental disabilities, those suffering from trauma, as well as the aging population. As far as VPBS beliefs and goals, our staff believe that all clients have the right to be accepted as unique and valued members of society. Our focus is on providing specialized and tailored care to our clients in a convenient and comfortable setting. Our goal of our programming is to provide hope in an environment that supports clients in achieving their maximum potential. As far as our staff, who are supporting our clients are supported by a team of mental health therapists, case managers, who we refer to as TBS, and I'll explain what TBS stands for here in a minute. Advanced practice registered psychiatric nurses, LPNs and RNs, which are nurses, collaborating psychiatrists, all to ensure the mental health of the whole client is addressed. So let's go over sort of our menu of services that VPBS offers, starting with case management. So VPBS is certified by the Ohio Department of Mental Health and Addiction Services to provide mental health and substance abuse services, including case management. And the umbrella of case management includes TBS, which is Therapeutic Behavioral Services, as well as community psychiatric supportive treatment. You may hear it referred to as CPST. So what does the umbrella of case management look like? So our TBS staff, or our case managers, support the restoration, rehabilitation, and they're supporting our clients' daily functioning to improve their self-management of the negative effects of psychiatric or emotional symptoms that are interfering with our clients' daily functioning. So case managers or TBS staff support our clients with restoring and implementing their daily functioning and daily routines that are critical to our clients remaining successful in their home, in their school, in their work, and in their community. Rehabilitation and support services restore our clients' skills, so hopefully they can function in their natural community environment. So what does it actually look like when case management is taking place? What are some examples of case management interventions? So throughout treatment, throughout case management, TBSs are constantly assessing clients' needs. That could be assessing their need for mental health treatment, could be assessing their needs for vocational assistance, for housing, really whatever their needs are, TBSs should be assessing it on an ongoing basis. Case managers or TBSs should definitely be supporting clients to achieve a higher level of independence on an ongoing basis. Case managers are always working with clients on building skills, activities of daily living, coping skills, Relaxation skills are just some examples of some skills that clients may be working on with their case managers, oftentimes in collaboration with their therapist. They may be working on the same skills in both therapy as well as with their case manager. Their case manager may be supporting their client in coordination of services. So when it comes to hospice, that could definitely be something a case manager is supporting is coordinating both with services that the client is engaging in hospice, as well as with case management to support their goals for treatment in both of those services. Case managers, TBSs are always monitoring symptoms when it comes to their client's mental health diagnosis to see if things are getting better, if things are getting worse, do they need to adjust goals and objectives on the treatment plan. Some more examples of case management interventions. The first one on this particular slide is crisis management. Now, when it comes to case management, TBSs are involved in crisis management, which is either preventing a crisis from occurring in the first place or responding to a crisis after it has occurred. Our case managers are qualified to only work on planning to prevent one to occur or responding after it has occurred. Case managers are definitely involved in advocacy, either advocating on behalf of a client if they are unable to advocate for themselves, or teaching self-advocacy skills to our clients, providing education and training to our clients, engaging our clients in mental health interventions under the guidance of the client's therapist, and definitely engaging the client in empowerment activities, helping the client to positively impact their environment. So just some examples of what that may look like if your client is engaged in case management. When it comes to crisis intervention services, these are only provided to our current clients. Crisis intervention is a face-to-face interaction responding to an emergent mental health situation that could include the following: an actual crisis assessment, immediate stabilization, determining the level of care for the client in the least restrictive environment. And all clients will be provided with contact information for after-hour crisis services in their area. As far as general services, VPBS is certified, again, by the Ohio Department of Mental Health and Addiction Services to provide the following services: mental health and substance abuse assessments, counseling, and pharmacological management. So let's talk about what those may look like. If your client is receiving counseling, therapists can support clients with things such as learning coping skills, working through relationship issues, dealing with loss and trauma, and other mental health, emotional, and life concerns that your client may be facing. It's very specialized and individualized care. Other services we offer could be medication management. We offer that service provided by a psychiatric nurse practitioner with collaborating psychiatrist oversight as well as nurses. Our nurse practitioners conduct psychiatric evaluations to determine the medication needs to address your client's unique symptoms. Clients then are able to continue with medication management every 1 to 3 months based on their unique assessed needs. VPBS nurses and nurse practitioners also provide follow-up care and will answer any medication questions that may arise, and will speak with clients about potential benefits and risks about any medication that is prescribed. VPBS does provide what is called deaf services. We have a specialized team of professional therapists, case managers who are deaf, hard of hearing, and hearing. And this deaf services team is fluent in American Sign Language to better serve individuals who are deaf and hard of hearing with emotional, mental, and behavioral health needs. So if you feel as though your client could benefit from any of those services that I just described, in addition to the hospice services they're already receiving, please consider referring them to VPBS. What would happen then after you made the referral to VPBS is that there would be an initial assessment or an evaluation to determine what services are appropriate for each client to meet their unique mental health needs. Based on that assessment or that evaluation, a treatment plan will be created to support your client to meet their identified unique mental health needs. So those are just the basic services that we provide. Let's talk for a moment about the different types of categories of mental health diagnosis that we typically see among our clients in VPBS. And so I'm going to talk in kind of generalities. I'm going to give you kind of just a quick basic overview. I'm not going to give you every single symptom of all of these disorders, but I just kind of want to give you an idea of what you may be on the lookout for if you're thinking about making a referral, or if you're thinking that one of your clients may be appropriate for our services. So we'll start with mood disorders as kind of the general first umbrella. And under mood disorders, the first one we'll talk about are depressive disorders. So some common features of a depressive episode involve having sleep or appetite disturbances, either sleeping more or less or eating more or less than is usual for that person, an increase in irritability or sadness, difficulty experiencing pleasure. Things that used to bring that person enjoyment no longer bring that person any happiness, fatigue, feelings of hopelessness or helplessness, social withdrawal, thoughts of suicide or death, a loss of motivation, and feelings of excessive guilt. So this depressive episode lasts at least 2 weeks and affects this person's emotions, thinking, behavior, their physical well-being, their ability to work, and their ability to have satisfying relationships. The second category under mood disorder is bipolar disorders, where the person experiences periods of depression as well as periods of mania, and I'll describe mania here in a moment. And those periods of depression and mania cycle. Some common features of mania are the person experiences increased energy, overactivity, they're easily distracted. They find they have a decreased need for sleep. They experience elevated mood or severe irritability. They'll notice rapid thinking and pressured speech or rapid speech. They'll find that they're involved in high-risk activities. They lack insight, and they have an inflated self-esteem. This manic episode lasts at least 1 week, and symptoms are present almost all of the time for that 1 week. So the next category is anxiety disorders. We commonly see those in VPBS. The first category under anxiety disorders are generalized anxiety is generalized anxiety disorder, where the person experiences severe ongoing anxiety that interferes with their daily activities. The second one is phobic disorders, where the person avoids or restricts activity due to fear of a specific object or a specific situation. So the person may have a specific social phobia, or they may have a specific phobia, for example, of spiders. That's called arachnophobia. The third type of anxiety disorder is having panic disorder with or without agoraphobia. And I'll describe agoraphobia here in a second. But this is the recurring panic attacks, as well as ongoing worry about the possibility of having a future panic attack. Could or maybe is not accompanied with agoraphobia, which is the fear of being in places where it is hard to escape, or where help may not be available if the person had a panic attack. This often causes people to avoid social interaction, as well as they avoid leaving their home. So let's talk about what are the symptoms of a panic attack. It could include heart palpitations, pounding heart, fast or rapid heart rate, chest pain, chest discomfort, sweating, chills, hot flashes, trembling, shaking, feelings of numbness or tingling, shortness of breath, feeling as though somebody is choking or being smothered, dizziness, lightheadedness, feeling faint or unsteady, abdominal distress, nausea, feelings of unreality, feelings of being detached from oneself, fear of losing control or going crazy, fear of dying. And some people report as though they feel like they're having a heart attack. The fourth type of anxiety disorder is obsessive compulsive disorder, which involves obsessive thoughts and behaviors that accompany the anxiety. So obsessions are frequent, uncontrollable, unwanted, repeated thoughts that affect one's functioning. And when we talk about compulsive behavior, that is performing an act repeatedly without it necessarily leading to an actual reward or pleasure. It can also be performed in an attempt to make the obsessions go away. So some examples, let's start with the obsessions. Some examples of obsessions could be fear of getting sick, thoughts of hurting oneself or hurting someone else. It could be thoughts of a certain sexual act. It could also be the need for organization or for symmetry. For example, needing to hang pictures, evenly spaced up on the wall, or that things on a shelf need to be organized in a certain way or stacked by color, by size, or by shape. Or it could be concern about, did I lock the door? Did I turn off the stove? And then checking it over and over and over again to make sure that I did turn off the stove or that I did lock the door, for example. So then compulsions would be actually checking, making sure that I did turn off the light, lock the door, turn off the stove, for example. It could be counting things like tiles on the floor. It could also be fears of contamination, washing your hands, germs. It could also be behaviors such as shopping, gambling, eating, hoarding, hair pulling, skin picking, things like that, then would also be compulsions or behaviors in an attempt to make those thoughts go away. So that would be a description of obsessive compulsive disorder. Number 5, PTSD, post-traumatic stress disorder. PTSD is a mental health condition that is triggered by a particular event, a terrifying event, either experiencing it or witnessing it. Most people who go through a traumatic event may have temporary difficulty adjusting and coping afterwards, but with time and with good self-care, they usually get better. If the symptoms get worse, if they last for months or even years and interfere with a person's day-to-day functioning, it could fit the diagnosis for PTSD. So some examples of events that we're talking about that could be traumatic to an individual are things like, physical abuse, sexual abuse, neglect, being in a car accident, being in a natural disaster, or witnessing a natural disaster are all examples of those traumatic events that could perhaps trigger PTSD. So some symptoms of PTSD are things like flashbacks, nightmares, avoiding triggers that are reminders of the event, severe anxiety, uncontrollable thoughts about the event, negative thoughts about oneself, other people, or the world, hopelessness about the future, experiencing memory problems, including not remembering aspects about the traumatic event, actually blocking out memories about the event, difficulty maintaining close relationships, having trouble trusting others, feeling detached from family and friends, lack of interest in activities that they once enjoyed, difficulty experiencing positive emotions, or just kind of feeling emotionally numb, not being able to feel anything. So let's go ahead and get an example of a definition of trauma. So trauma results from an event, a series of events, or a set of circumstances that is experienced or is witnessed by an individual as physically or emotionally harmful or life-threatening and has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. It is also a result of anything that disrupts one's sense of safety. So there is a very wide range of events that could potentially cause trauma. A person can experience it themselves, or they could witness the traumatizing event. It can be caused by events that the individual doesn't remember. We just learned a couple slides ago that a person can block out those memories, so they may not even remember the event. It could have occurred in early childhood. It can be caused by events that are well-intentioned and necessary. For example, a medical procedure. It could be life-saving, but it can also be traumatic. A trauma can be caused by an event, like I said, that did not actually happen to the person, but maybe they witnessed it, or it could be something that happened to a group that a person identifies closely with. For example, if a person is Jewish, the Holocaust could be traumatic for them, or something that occurred to a group such as Native American people, if a person is Native American, or slavery, if a person is African American, for example. Over time, chronic stressors can accumulate to also then be traumatic. So there's a very wide variety of things that can sort of fall under this category of trauma. So kind of bringing it back to VPBS staff in trauma, we are trained to be trauma informed and to provide trauma informed care. So what that means is our staff are trained to recognize just that wide variety of trauma, that it is likely that our clients have experienced some sort of trauma and that it may play a large role in our client's life. We are trained to recognize it. And we will learn more about trauma-informed care in a little bit in this training. We also want to point out that are the clients that we serve that are within the intellectual and developmental disabilities population have experienced trauma at a much higher rate and a much higher prevalence than the general population. And the individuals that we serve in VPBS in our residential settings, as well as in our day and employment services programs, who have co-occurring mental health diagnosis, as well as intellectual and developmental disabilities, are also likely to have a trauma history as well. So we just want to make it known that we also need to be sensitive to that population as far as trauma is concerned. So moving on to psychotic disorders, there are several different types that fall under the category of psychotic disorders. The first one is schizophrenia. The markers of schizophrenia are that the person could be experiencing delusions, hallucinations, and I'll explain those here in a minute. They could be experiencing cognitive difficulties, loss of drive or loss of motivation. They could be experiencing numbed emotions. They could be withdrawing socially. Schizoaffective disorder is the second one with the same symptoms listed above, as well as a mood disorder, either major depressive disorder or bipolar 1 or 2. The third one is delusional disorder, where they do not experience hallucinations, but they are experiencing delusions. So let's learn about hallucinations and delusions. Hallucinations are the experience of seeing, tasting, smelling, or being touched by something that is not there. So visual hallucinations could be that the person sees shadows, sees people, spirits, animals that are not there. Auditory hallucinations, the person hears things, voices, noises that are not there. Tactile hallucinations, where they are feeling things such as bugs crawling on their skin, someone tapping on their shoulder, that is not really there. Olfactory hallucinations where they smell things. Sometimes it's blood or certain foods that is not actually there. And then gustatory hallucinations where they taste things that is not actually present. So delusions, which is described as impairments in thought patterns that are not based in reality. There's different types of delusions. There is eromanic type. That is a delusion that another person, usually of a higher status, is in love with them. Grandiose type of delusions, that the person has an inflated sense of self, of knowledge, of identity, or of a relationship, that they are perhaps famous. Jealous type, that they are thinking that their partner, for example, isn't being faithful to them. Persecutory type of delusion, that they think that somebody is treating them unfairly, the government is out to get them, is a common one. Somatic type, they're having thoughts that they have a medical condition that they do not have. So many different types of delusions that could be falling under that category. And then the last one we're going to learn about is personality disorders. We're not going to go into all of them, but just in general, personality disorders are characterized by a rigid and unhealthy pattern of thinking, functioning, and behaving. The person may have trouble perceiving and relating to situations and people. It causes a significant problem in their relationships, social activities, work, and school. And then it is described as a pattern of personality traits that have developed over a long period of time. There are 10 subtypes of personality disorders. The one that we see the most often, and that it is diagnosed in folks who have intellectual and developmental disabilities, is borderline personality disorder. Just kind of quickly, some characteristics of borderline personality disorder are things such as impulsive and risky behavior, things like having unprotected sex, unsafe sex, gambling, binge eating, having an unstable self-image as an ongoing struggle, intense fear of being alone or abandoned, unstable and intense relationships, up and down moods, often as a reaction to stress, suicidal behavior, threats of or actual self-injurious behaviors, ongoing feelings of emptiness that cannot be filled, frequent, intense displays of anger, and stress-related paranoia that comes and goes. So that's just one of the 10 types of personality disorders. Like I said, it's most common in folks with intellectual and developmental disabilities that we tend to see most often in the clients that we serve. So having gone over all of those most frequently served diagnosis and the clients that we work with, this is a good time to just mention that our staff are trained to be aware of all of these mental health symptoms, including suicidal and homicidal ideations, and to recognize them when they occur in our clients. A lot of times when we see these behaviors, they are actually symptoms, and they are a result of the mental health symptoms that our clients are experiencing because of their diagnosis. Our staff, because they are aware of diagnosis and symptoms, can then assist with our clients and support them to hopefully increase successful interactions with our clients, and then support in de-escalating our clients and help them to make safer choices. A little bit later, we're going to talk about specific de-escalation techniques that we are trained in VPBS. But let's switch gears here a little bit and talk about mental health medications. I'm going to actually defer here in a minute to Cassie Skull, who is our Director of Nurse Practitioners, but I'll give you some general information to get us started that just kind of generally, mental health medications are used to treat a lot of the symptoms that I just went over for diagnosis, such as schizophrenia, depression, bipolar disorder, anxiety, and so on. A lot of times, best practice is to use medication in combination with other treatments, such as psychotherapy. Medications treat the symptoms of mental health disorders, but a lot of times it affects clients differently. Some clients require only short-term use of medications. Other clients require long-term use to manage their symptoms effectively. All medications have the possibility of side effects. What side effects people experience varies from person to person. Side effects can lessen or resolve completely once the body gets used to the medication. Sometimes the benefits of the medication outweigh experiencing the side effects. So I'm gonna, like I said, defer to Cassandra Skull, who is our Executive Director of Nurse Practitioners. She's gonna provide the information on the next couple of slides about specific medications because I am not a nurse practitioner. So I'm gonna go ahead and have her share the most common medications used to treat the diagnosis that I just shared that we most commonly see in the clients that we treat.
So there are a variety of medications used to treat depression. Probably the most common are something called the SSRIs, or the selective serotonin reuptake inhibitors. So you're going to see things like Prozac, Celexa, Zoloft, Paxil, and Lexapro. Probably a little less Paxil because that can cause a little bit increased in side effects. Another class are something called the SNRIs, or the selective norepinephrine reuptake inhibitors, such as Effexor and Cymbalta. The biggest things when I think of them is that they have to be decreased very slowly because they can have almost withdrawal issues. So a lot of side effects when you're discontinuing those. There's some that don't have a class of their own. The most common is something called Wellbutrin. Wellbutrin is used quite a bit. It's really good for those patients who are depressed and maybe having a lack of motivation, really quiet, very not wanting to do much. And then we have a lot of different ones. The tricyclic antidepressants are definitely used less often, but we do have, there is a time and a place for them. Mirtazapine or Remeron is very commonly, you'll see very, very commonly prescribed, especially in the nursing home populations. It's great for appetite, sleep, and depression. You have something called the MAOI inhibitors. Very, very, very rarely prescribed. I have never prescribed it myself. And the big thing to know with those is that there's a lot of dietary restrictions. So what are we looking for when we're treating depression? Of course, we're looking for a decrease in their depressive symptoms. So we want them to, when you think about stuff, the symptoms of depression, you think about, just feeling blue, not wanting to do anything, maybe having anxiety. Some possible side effects: headache, see that a lot, nausea, drowsiness. On top of that, it could be not drowsiness, but you could also or have insomnia, agitation, feeling jittery, issues with sexual dysfunction, dry mouth, constipation, bladder dysfunction, and blurred vision. Drugs that we use to treat bipolar disorder are called mood stabilizers, or we can do some of the second generation or atypical antipsychotics. The most common mood stabilizers are lithium, Depakote, Tegretol, Lamictal, and Trileptal. And then the most common atypicals that we use to treat bipolar are Zyprexa, Abilify, Risperdal, Geodon, and Clozaril. And then remember, Clozaril is only used after 2 failed trials at least due to the side effects. So what are our desired outcomes for these medications to treat bipolar disorder? We'd want the resolution of the symptoms of mania. So again, mania is the high, hyperactivity, pressured speech, poor judgment, driving too fast, sleeping around, spending too much money, gambling, need for little sleep. Sometimes they're very goal directed, so they're doing lots of things. All of a sudden at 3 a.m, they're going to write the next great novel. It's hard because there are spells that are hypomania. So just a little bit of this. And a lot of people feel good when they're in that hypomanic state. So it's not to the point that it interferes as much in their life. And a lot of times they maybe not want to get treated because they like that feeling. It can be a very good feeling. We want a decreased incidence of mood swings, a decreased incidence of those very acute manic episodes, less depression, no delusions or hallucinations, and less social withdrawal or blunt affect. Affect is kind of like how you present yourself, your mood. So somebody who has a blunt affect would be like, "Hi, how's it going? My name is Cassie." Where somebody who has a regular affect is like, "Hi, how's it going? My name's Cassie." So it'll be different. You'll hopefully see a little less of that. Some possible side effects of the medications: a loss of coordination, excessive thirst, frequent urination, blackouts, seizures, slurred speech, a fast or slow, issues with the heartbeat. Some people can have visual auditory hallucinations, changes in vision, itching or rash, edema, which is also known as swelling. Anxiety disorders can be treated by a lot of different types of medications. So the antidepressants, what we just talked about before. So your SSRIs, your SNRIs, your tricyclics, those all can be used for anxiety disorders. The other class that you think about, big class, is the benzos, so which are controlled substances. They get a very, very bad rap because they have a high addiction potential, but they are very effective at treating anxiety. So things such as Klonopin, Ativan, or Xanax. The way that most prescribers look at it is that there's a time and a place for a benzo. They are definitely used more in populations with intellectual or developmental disabilities. They can work very well. I've seen them work, have a paradoxical reaction though. So something that's supposed to calm them actually does the opposite. So it can actually be agitating in that population. So sometimes you don't know. Then there's the anti-anxiety agents such as Buspar that can be used. It's non-addicting. It can be very useful. And then beta blockers are a type of blood pressure medication. It slows the heart rate. So propranolol, metoprolol can be used also to treat anxiety. If you think about anxiety, the physical components of anxiety or panic disorder, heart's racing, you're jittery. The beta blockers are very good with that. Sometimes people will utilize this for test anxiety. So some possible side effects of the benzos can be upset stomach, blurred vision, headache, confusion, grogginess, nightmares. The big thing you can also think about with people with impaired mobility or the elderly are falls. that can be quite can cause quite some damage. And you know, can you imagine an elderly frail person who's took a Ativan for anxiety and fell, then they broke their hip, and now they're in another world of hurt with a different problem. The beta blockers can cause fatigue, cold hands, dizziness, weakness. Um, Probably have to be very careful moving positions. Boost bar can cause dizziness, headaches, nausea, nervousness, lightheadedness, um, insomnia, excitement. It can have like a paradoxical or an opposite reaction. So there are some interactions with a lot of the medications for schizophrenia. So it can cause hypotension or low blood pressure when used with alcohol or blood pressure medications or nitrates. Phenobarbital is a anti-seizure medication, can increase the metabolism and decrease the effectiveness of the antipsychotic. It can cause worsening of that central nervous system depression. So you got to be careful when using alcohol, the antihistamines like Benadryl, the antidepressants, pain medications like opioids, or the sedatives or the sleeping pills, the hypnotics. Lithium can decrease blood levels and the effectiveness of antipsychotics. So sometimes you may need to increase the antipsychotic if the patient is on lithium. And then cautions for any and all medications. You always notify the mental health provider if the side effects are sudden, severe, and or negatively impacting the client's ADLs or their health. I rather have somebody raise a false alarm than to miss something that could be life-threatening. Again, I always say trust your gut. A lot of times, if you're a DSP or you're in you know, if you're in these patients' lives more often, you know them, you know their baseline, you know when something's not right. So I always say trust your gut, and I rather have something be brought to my attention that turned out to nothing than to not have something brought out into my attention and find out my patient's in the hospital.
Okay, so thank you very much to Cassie for sharing that information. I think it was a good recap, again, not only of the diagnosis that we tend to see, but also some great information about commonly prescribed medication. And then also just a great reminder to, share information among team members about monitoring symptoms, sharing information about side effects, monitoring side effects, providing education to clients about medication is things that we can all do, no matter what your job title is, no matter what your no matter what your role is, we can all do those things. And a great just reminder to communicate not only to the client, but to communicate to other members on the team. So thank you again to Cassie for that information. Our last topic for this particular training is to kind of come back to one of the ideas that we sort of touched on in the beginning, which is to kind of again revisit trauma, but with a focus on how we can keep that in mind as we are working with our clients to keep them safe, and to kind of give you a little bit of insight into how VPBS staff work with clients with trauma in mind to keep them safe as we are working to de-escalate them. So you kind of understand where VPBS staff are coming from as we are trauma informed to keep clients safe to de-escalate them. So let's just kind of get into that topic. As you may be considering making a referral for your client to VPBS. So as I stated earlier, our staff are trained and encouraged to be trauma informed in their interactions with their clients. Just as a refresher, trauma informed care recognizes the presence of trauma symptoms and acknowledges the role that trauma may play in their client's life. Additionally, our staff are trained to see behavior as communication. And I'm going to kind of break that down for you in the next couple slides. And I'm going to start with what kind of behaviors am I even talking about when I keep saying behaviors? Earlier, I talked about how these behaviors may actually be symptoms of a mental health diagnosis. Additionally, I'm also talking about behaviors, in addition to being a symptom of a mental health diagnosis. More specifically, they may also be harmful, perhaps, to that client or to those around them. These behaviors may be interfering with the client's life or with the lives of those around them. They may also be disruptive to the client's life or perhaps to social interactions. So those are the kind of behaviors that we are talking about. So what we learn in a lot of the trainings, in our crisis de-escalation training and other trainings that VPBS staff get, is that behavior is communication and that also behavior is functional. There's usually a reason why our clients and people in general are behaving in the way that they do. Behavior is often learned through imitation. It is often learned using trial and error. We also learn that behavior is used oftentimes to communicate an unmet need. Behavior is an action. Behavior is observable, and behavior is measurable. So we're talking about something that we are looking at, something that we are watching, something that we can measure when we talk about behavior. So usually behavior is part of a sequence, and it doesn't just occur out of nowhere. Usually when we're talking about behavior, there is a situation or there is a trigger. We often refer to it as an antecedent. What happened before the behavior? Did somebody say something? Did somebody look at you a certain way? Did somebody touch you? What was it that happened before the behavior? Then the behavior occurred. And then what was the consequence? What happened after the behavior was demonstrated? So we have this kind of ABC model that we use usually when we're talking about a behavior. And as part of a sequence, we usually use this ABC model. Just a minute ago, I mentioned that oftentimes behavior is used to get a need met. So I have a few minutes here. I'm going to go ahead and just give you a brief overview of Maslow's hierarchy of needs. Some of you may have heard of Abraham Maslow, maybe in another training or maybe in a class that you took. If so, this will be an overview or it'll be a review. If you have never heard of Maslow, I'll just give you a really quick overview of Maslow's hierarchy of needs. So Abraham Maslow was a Jewish Russian psychologist. His family immigrated to the US, like I said, from Russia. He was alive from 1908 to 1970. He was a psychologist who studied positive human qualities in the lives of kind of exceptional or exemplary people. And through that study, he came up with this hierarchy of needs. It looks like a pyramid. And what he came up with in his book titled Motivation and Personality is that people strive to get their most basic needs met. So at the bottom of the pyramid, you'll see our most basic kind of physical or physiological needs are first. So, just kind of obviously we need food, we need air, we need water, we need warmth, We need rest just to live on a day-to-day basis. If we don't have those things, we're not going to make it, very long without those basic kind of human needs. Once we have our basic human needs met, we have our food, we have our water, we have our shelter, we're able to sleep. Once we have those things met, then we can focus on feeling safe, feeling secure. And that could, be different from one person to the next. Safety could, for some people, be money. Safety for other people could be living in a safe neighborhood. For other people, safety could be knowing that you have a job. So that could look a little bit different, depending on your situation, depending, on your circumstances. But it's described sometimes as security of the body, employment, resources, security for your family, health, or property. But after you have your physical needs, your basic needs, you have your safety needs met, kind of human beings' next focus is belongingness and love. So relationships, friendships, family, sometimes sexual intimacy goes in there. You're finally kind of free to focus on love, to focus on belonging. Those types of relationships is kind of where your next focus is. Once you have those relationships established, that's when people kind of have the base to what we call self-actualize, achieving one's full potential, being creative. Other things that fall under that category are appreciating beauty. So creativity, able to be spontaneous, problem solving, acceptance of facts is another thing that falls under that category. Kind of reaching your full potential is another way. Self-fulfillment is another way to describe self-actualization. And this also looks different from one person to the next. One person's self-actualization might be graduating from high school. Somebody else's self-actualization could be painting, a beautiful picture. And sometimes people fall kind of in and out of self-actualization, depending maybe on other needs that are below it. If those aren't met, maybe they aren't able to be self-actualized. So this theory has changed over the years, but that's kind of the basics of Maslow's hierarchy of needs. If you hear it referenced, that's what it's talking about, that people have basic needs that need to be met. And usually one need comes before the next, comes before the next, comes before the next, and they sort of build upon each other. But kind of what we're talking about, to come back to behavior, is that it is communicating oftentimes that there is an unmet need if somebody is displaying a certain behavior. It is hard to focus at school if you're hungry. It's hard to do well at a job interview if you're cold or if you're dehydrated, so a lot of times behavior can be communicating an unmet need is what we're talking about. When it comes to trauma is when we're thinking about behavior theory. When we're keeping people safe, sometimes behavior can be communicating that I don't feel safe, that I don't feel like I belong, I'm not feeling loved, I don't feel accepted. Behavior can also be communicating those type of needs. So that's just a really quick history lesson about Maslow and how it could be playing into your client's behavior, what it might be communicating. I really also want to focus on that a person's needs can be actual or perceived, and it differs from person to person. In spite of us not understanding, it may be still very real to the person. And kind of an example about that might be, perhaps you go to your client's house, you open up their cupboard, and to you, when you open up their cupboard, you see cans of food, you see boxes of cereal, you feel like that person has enough food to get them through the next couple of weeks. But maybe to them, they feel like they don't have any food. Maybe they went through a time in their life where they had food insecurity. They They went through a time where their needs weren't being met when it came to food. And so they would prefer to have a full refrigerator, a full freezer, all of the cupboards full of food. So to them, they feel like they don't have enough food, but to you, in your opinion, they have enough food for the next 3 days, so they have enough food. So a person's needs can be actual or perceived. What matters is how the person feels about their needs being met. That's what matters. Not really necessarily our opinion about their needs. So kind of also keep that in mind. It's their perception of their needs being met, not our opinion of their needs being met. So that really relates back to trauma. Behavior may be a response to trauma or a reminder of a previous trauma. So we're going to talk for a second about that. In specific, we're going to talk about the Center for Disease Control, who did a huge study on adverse childhood experiences, or ACEs, which are potentially traumatic childhood events that occurred during a person's childhood, ages 0 to 17. Things like experiencing violence, abuse, or neglect, witnessing violence in the home or community, having a family member attempt or die by suicide, growing up in a household where there were substance abuse problems, mental health problems, parental separations, or household members being in jail or in prison. Any of those would fall under the category of an adverse childhood experience. So the CDC did this huge study, and this is what they found about adverse childhood experiences. They were linked to the following then in adulthood: chronic health problems, mental illness, substance abuse problems, and then adverse childhood experiences negatively impacted a person's education, job opportunities that were available to them, and their earning potentials as an adult. They can definitely increase the risk of injury, sexually transmitted diseases, maternal and child health problems, teen pregnancy complications, and a wide other variety of chronic diseases. So they just went on to affect many other things in the person's adulthood based on what they experienced in childhood. And they are much more prevalent than you might think. What the study found was 61% of adults surveyed across 25 states found that they experienced at least one of the type of adverse childhood experiences, and nearly 1 in 6 reported they experienced 4 or more types of adverse childhood experiences. So much more common than we would have thought. So that is why it is so important to become trauma informed. And again, trauma informed means that staff assume an individual is more likely than not to have had a history of trauma. Trauma informed care recognizes the presence of trauma symptoms and acknowledges the role trauma may play in an individual's life. So what this means to be trauma informed is that we are recognizing the potential for re-traumatization, that it exists in all levels of care, from individuals, from staff, and from systems, and from organizations. Re-traumatization is often unintentional. There are some obvious practices that could be re-traumatizing, such as using restraints or isolating our clients. But less obvious practices or situations that could be re-traumatizing could be smells, maybe cleaning products, or the smell of bleach could be re-traumatizing to somebody who had a medical trauma, or who was hospitalized, or was institutionalized. Other sounds or types of interactions could cause individuals to feel re-traumatized. We have to kind of understand what their trauma was originally to understand what could, re-traumatize somebody again. So here are some behaviors that you may recognize in a client that could be evidence that they are displaying behaviors that they may be a trauma survivor. A person who has experienced trauma may display a flight, fight, freeze, or fawn response. That is kind of a person's survival technique. This is what helped them to survive the trauma to begin with in the first place. And they may sort of be in that survival mode still to this day. That flight, fight, freeze, or fawn response helped them to survive the trauma, and they may still be in that survival mode to this day. So people who are workaholics, who have anxiety, panic disorders, obsessive compulsive disorder, who have trouble sitting still, or who have perfectionistic tendencies, are in that flight mode. Always being on the go, never stopping. Maybe that was how they got through their trauma originally, and that is still maybe working for them today. Sometimes you'll see that in your clients. People who are in a fight mode, and that is how they survived their trauma the first time, to this day, you may see them being more angry or irritable. They may be acting the part of the bully. They may have more explosive behavior. That's how they survived their trauma, and that's how they're continuing to survive today. Other responses could be a freeze response. That's how they survive their trauma, and they're continuing in that survival technique today. You may see them having trouble making decisions, dissociating. They may numb their emotions or just not experience any emotions. The last response is what's called a fawn response. Those are the people pleasers. They may not have good boundaries. They may feel overwhelmed by their emotions or be more codependent in their relationships. So all of those responses are just how a person survived their trauma, and they may still be displaying those trauma survival techniques today in their relationships, or you just may see them still displaying them, and those symptoms may show up perhaps in their diagnosis. So what we want to do is sort of look beyond the behavior and looking to identify an unmet need. So our job and what we are taught as staff is to figure out what could be fueling that behavior. So some questions we want to ask ourselves is, what happened to the client? What could have been their trauma, and what do they need? What are they trying to communicate? Is this an attempt for the client to deal with internal factors or to maybe gain control over their environment? We want to avoid questions like, what is wrong with this client? Or we want to avoid taking it personally. So don't ask your question to yourself, why is the client behaving this way towards me? Now, try not to take it personally. So the question should be, what can I do to help this client? What are they trying to communicate, and not what is wrong with this client, or why are they doing this to me? Our job is to figure out what is fueling the behavior, ask questions like, why is this behavior challenging? Ask questions like, how severe is this problem behavior? Ask questions like, is it distracting, disruptive, destructive, or dangerous? We want to pick our battles. If it is not distracting, disruptive, destructive, or dangerous, maybe we don't need to address it at all. Maybe it's working for the client and we can let it go. So it's important to remember that behavior is value neutral. It's the consequences of the behavior that are positive or negative, and even that is subjective. So if it isn't hurting anybody, if it isn't destroying anything, if it isn't dangerous, if it isn't disruptive, do we even want to address it at all? So we want to be mindful, pay attention to the behavior, think about its purpose, and do our best to not just react. What we learn as staff is to slow down, pay attention to what is happening with us, try to be professional about it. And we want to make sure we're coming from a place of empathy and not sympathy. So just kind of quickly, the difference between the two is empathy is the ability to understand and share with the feelings of another. You're kind of feeling with somebody. Sympathy, on the other hand, is more of pity or sorrow for someone. You're feeling bad for someone. The best example I can give you is somebody recently told me at a training that her father had passed away, and somebody came up to her at the funeral and told her, oh, well, at least you still have your mother, completely ignoring the fact that she had lost her father. So to me, that is, ignoring their feelings. That is not having empathy. Empathy would be having feelings with her and not ignoring their feelings. So sympathy is feeling, bad for somebody. Empathy is feeling with them. Sometimes we don't know what to say, and so we sometimes say the wrong thing. So I really like to show this video that really, I think, um, demonstrates well empathy versus sympathy. You may have seen it before. It's very popular to show in trainings by Brene Brown, who's like the foremost expert lately on empathy. I'm going to go ahead and just show it. And then on the other end of it, I'll say a little bit about empathy versus sympathy.
If you only list your vacation home on Airbnb, there will...
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Okay, so I really like that video. I show it for a couple different trainings that I've done because I think it really just illustrates well, especially when we're on the topic of, responding to de-escalate clients or responding, with empathy, that a lot of times, like she said, there's nothing really that we can say, but it is just our presence that can help to de-escalate. It's just us being there that can communicate our empathy, to feel with our client instead of sympathy. Not always helpful to de-escalate the client. So, which is exactly kind of the next slide here, that our behavior as staff is communication too. So how can we respond when clients are displaying unsafe behavior? We want to start by trying our best to understand the behavior and its purpose. What could this behavior be trying to communicate? Maybe we want to do something different to plan ahead so this behavior is less likely to occur. If we understand what are our client's triggers, can we not put our client in that situation where they are likely to be triggered? Is it a smell? Is it a sound that is triggering to our clients? Is it certain staff that remind our client of somebody? Is it that there is an anniversary that is coming up? Can we make other arrangements? Can we do something differently so that this behavior is less likely to occur? Intervening only as necessary for safety. Again, making sure that we're following company policy. Always, always, always showing respect to our clients in all interactions. Teaching acceptable ways for our clients to get their needs met. Giving as many options as possible if we can. Considering our own behavior and what that is communicating. Is it our tone of voice? Is it our posture? Is it our body language? Are we giving too much eye contact? Are we not giving enough? Would they prefer to be called something else? Are we not honoring their request to be called a certain name? Are certain words triggering to them? And so on and so on and so on. Did they ask to be met with at a certain time? And are we not honoring that request? Are we part of the problem? Is it something that we're doing or not doing that is leading up to these behaviors? Is it something that we're doing or not doing? If possible, get support from your coworkers and your supervisor. Run situations by your coworkers. Ask questions to your supervisor. You might be missing something that they may see that you're just not seeing. Remember that behavior satisfies a human need and it's working for the person. A new behavior must work better for them to do something differently. Sometimes it's easier for your client to focus on what to do instead of what not to do. So nobody wants to hear no. What is easier to hear is you can do X, Y, or Z. So maybe instead of saying no, give options of what your client could do instead. Thinking about the big picture, always putting your person first, thinking about their best interests before anything else. And then number 12, always reflecting on your relationship with the clients. I know something that used to work really great with a lot of my clients is reminding them, we've gotten through this before, we can get through this again. Remind them of past successes. We've solved this problem, or we've solved problems like this before in the past. We can probably solve this if we just think about it. Remember that when people trust us, they feel safe and they're more likely to feel in control. Trust comes from us saying what we mean, meaning what we say, and then following through. So if you can't do something, don't promise it. Don't make empty promises if you can't follow through on it. So those are just some general tips on how to respond to behaviors, some things to think about, just so you kind of know where VPBS staff are coming from, and just so that you know what our staff are told in trainings that they receive. This is what we're told, and this is kind of the philosophy that we take when we're supporting our clients. So we're just going to end with making a referral to VPBS. If you like what you've heard, if you think some of your clients could benefit from case management, from therapy, from medication management, or from nursing, or from deaf services, or any of the other services that we talk about, you can either fill out a referral form. This is what it looks like. My biggest tip is just to make sure that you have filled out as much information as possible, especially under the presenting problem. Give us as much information as you possibly can as far as why the client should be seen, checking any current mental health symptoms. But remember, your person will get a thorough assessment or a thorough psych eval to determine the appropriateness of services. But that's what the intake referral form looks like. Other options are that you can either call. Oh, sorry, I lost my slide. You can either call intake. The number is on the intake form. There we go. So you can either call, and there's the phone number, 855-289-1722 with questions, or feel free to email intake, pbsintake@viaquestinc.com. If you do fill out the referral form, there is the number to fax it. It's also listed on the referral form. So hopefully you found this training informational. Hopefully it answered your questions as far as what VPBS does and how it could be helpful to your clients. So here are the references that I used to come up with the training today. If you have any questions, please don't hesitate to contact me. Thank you for your attention. I appreciate it. And I hope you have a great day. Thank you.